So today we are going to talk about drugs used in breast cancer, and our objectives would be to briefly discuss the treatment approaches in breast cancer, and then we'll rationalize the pharmacotherapy in the management of breast cancer, and we'll talk about various drug classes and their use in the breast cancer, including their use as part of chemotherapy or endocrine therapy or targeted therapy, and we'll talk about the mode of action and adverse effects and important aspects of those drugs. And the important thing is we'll be focusing only on pharmacologic therapy. But when it comes to such issues like the malignancies, so there are always non-pharmacologic therapies which are very important, like surgery and radiotherapy. So we are not focusing on that. We are just talking about pharmacotherapy. And again, this pharmacotherapy, and when it comes to cancer therapy, it's a huge area, and a lot of research going on. Every day new drugs are coming in, so you have so many drugs and so many classes, so we cannot cover everything. So we'll just touch upon few important things, and hence you will hear and I'll talk about many drugs and many classes, and some of which probably I think at this stage you don't need to know, and we don't want to burden you with so many drugs, but for the sake of completeness I would like to mention them, but they won't be tested. So the slides which are not tested in the exam will have this red cross mark on top of them. So the slides which have this red cross mark are not part of your exam. Okay? But because when it comes to chemotherapy as well as the targeted therapy, there are many new drugs which are being used, and you will be tested not in this exam but later in your life in all the licensing, because breast cancer is a leading cause, leading cancer in females, and wherever you go, whichever country you practice in, and if you take their exams, they will test you on therapies of breast cancer, so you will face these questions. And by the time you do those exams, you will have even more drugs, the newer agents in the market. So just to familiarize you with those names, I have mentioned them, but the drugs which have this class mark are in some other slides where the slide is part of the exam, but then there is some element which I think is not needed, then I have written that in grey. Okay. So anything written in grey, light grey, is not part of your exam. Okay. And then in the next slide, the rest of the content is part of the exam and you will be tested on it. And on the next slide, I've given you formulary. So those drugs are part of the exam and you will be tested on those drugs. Which are these? So these are the drugs which are part of your exam, okay? And you will be tested on this. Besides them, like the rest of the names, you don't need to worry about them. And these names, again, like you see around 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, so 10, 11 names, but all of these most of these you have done already, POD and in other blocks. Like all the chemotherapy agents, like 1, 2, 3, 4, there are 5 chemotherapy agents, cytotoxic chemotherapy agents, which you have done in POD, and then the other blocks as well. And then the hormonal therapies which you have done in POD, and then some of these drugs you might have done in the repro, like recently. So only there may, and this pembrolizumab I have already covered with you. So only probably fulvestrant and ribociclib may be new names. The rest of these things you know. Okay? So far good? So do you remember these drugs? So if I ask you what is doxorubicin? Answer is good. And how does it work? Sorry? Okay, gene intercalation and topoisomerase inhibition. And what is in so most of the the first 5 chemotherapy drugs, all of them will have one common side effect, which is all of these will cause nausea, vomiting anyway, so we don't accept that if you write that in exam. But besides that, one common side effect of chemotherapy will be myelosuppression. So myelosuppression is common in all of these 5. But any other atypical adverse effect of doxorubicin or anthracyclines? heart, cardiotoxicity, yeah? Good. And then there may be a couple of other things that we'll talk about. What about cyclophosphamide? How does it work? Cyclophosphamide is it? No, it's not an antimetabolite. A sterilizing agent, okay. And what does it do? Huh? Does it transmit the DNA? Okay. And any, besides myelosuppression, any other hemorrhagic cystitis? Huh? And people test you on this thing, hemorrhagic cystitis, especially in USMLE. Why did I mention this Mesna with it? Yeah, so if you give Mesna with such a cyclophosphamide and adequate hydration, then you can avoid this adverse effect of hemorrhagic cystitis. So this Mesna, cyclophosphamide, and other like ifosfamide of the similar drug, they cause this hemorrhagic cystitis. So you can either they'll ask you, we started somebody on some chemotherapy drugs and then they developed hemorrhagic cystitis, and which drug was probably used, and which drug could have been used to avoid this thing, or something like that. Okay, methotrexate, antimetabolite, and it inhibits dihydrofolate reductase. Good. And why did I mention folinic acid with it? Glucose. So we're trying to avoid the adverse effect of folic acid reduction inhibition on the normal cells. Huh? So we're trying to rescue the normal cells, not the cancer cells, with this drug, folinic acid or leucovorin. So it doesn't need reduction, so it doesn't need dihydrofolate reductase. 5-FU, 5-fluorouracil, is an antimetabolite, okay. And inhibits what? So we have many other slides, but like I'm trying to cover the whole lecture on the very first slide. We'll go over these things, but lecture. Tablet synthetase, huh? Because it's a uracil, so it functions as a uracil analog. Okay, so that's why it enables the tablet synthetase. Okay, so all of these are affecting the cellular division, and they are cytotoxic, and that's okay. What about paclitaxel, docetaxel, taxanes? What do they do? They inhibit microtubular what? Polymerization or depolymerization? Depolymerization, huh? And which ones inhibit depolymerization? Yeah, so which category of drugs? So there's one category of drugs which inhibit the depolymerization, which is this one. But then there's another category of chemotherapy drugs which inhibit the polymerization stage of this spindle formation. So when the spindle forms, so initially there's microtubular polymerization. That's how it forms. But then it needs to disintegrate. So there's a depolymerization. So this category of drugs inhibit the depolymerization. So that doesn't let it separate. Like so it gets stuck over there. But which? Maybe, but like I'm talking about chemotherapy drugs. You know, Vinca alkaloids, vincristine, vinblastine. So they inhibit the polymerization stage. Okay, and then we come to this trastuzumab. What is this? It's an antibody. It's HER2, huh? HER2 receptor. Good. And what is tamoxifen? Selective estrogen receptor modulator, SERM, huh? Good. Anastrozole, aromatase inhibitor. Good. Do you know fulvestrant? Again, something similar. It's again like hormone therapy. It's estrogen receptor degrader or down regulator. It's SERD. Instead of SAM, it's a SERD. Selective estrogen receptor down regulator. So it down regulates those receptors. So similar effect. And then ribociclib. Can you be a little louder? Sorry? No, it's not CD4, CDK. These are cyclin dependent kinases, 4 and 6. So if you remember the regulation of cell cycle, the cell cycle progression depends on the role of certain cyclins and cyclin dependent kinases. So this is an inhibitor of cyclin dependent kinase 4 and 6, and it again leads to the arrest of the cell cycle and leads to arrest in the cell growth. Pembrolizumab, we have done this previously, I think, in probably lung cancer treatment. Yeah, so it's again immune checkpoint inhibitor. Is it PD-1 antibody, anti-PD-1 antibody? Okay. Not PDL also. So this is anti-PD-1 antibody. Okay. So you know all these drugs. Okay, so you don't need to worry about this. Good. Now let's go over the slides. So treatment approaches in breast cancer, we have, now again, like somebody has cancer, so we have two options. Either the disease is probably limited and curable, like you can cure the patient of the disease. Or the disease has spread so much, is so much extensive that you cannot cure them. And then you want to just improve their whatever time they have left, you want to make sure that the symptoms are controlled and the survival is slightly prolonged, and they can have a pain-free and symptom-free time. So that's called palliative intent. So we have two intents, like curative intent versus palliative intent. Okay. So in curative intent, it's like and usually when it comes to breast cancer, so we are talking about the stage 1, 2, and 3 disease. Okay. And someone who has already metastatic disease, which is stage 4, or if the local tumor is so extensive and is involving certain vital organs so that you cannot resect it, so in those cases, then you have palliative intent treatment. Okay, so we'll first talk about curative intent, then we'll talk about palliative intent approaches. When it comes to curative intent, so again you have surgical resection, and then we will not go into details. So you can have different types of surgical procedures, whether it's breast conserving or total mastectomy, depends on the situation. Then you have radiotherapy, and then you have adjuvant systemic therapy, and then you have neoadjuvant therapies. And I hope you remember adjuvant versus neoadjuvant, huh? So adjuvant is what, like before surgery or after surgery? After surgery. Neoadjuvant is before surgery. And adjuvant systemic therapy can include chemotherapy and can include targeted therapy, which is targeting specific receptors like HER2 receptors. Patients who have HER2 receptor positive, then you can target them with those drugs. If they are hormone receptor positive, then you can target them with the endocrine therapy. Also, you need to give the bisphosphonates, and then you need to give, like, if an older woman, is slightly different approach, and then you have neoadjuvant therapy. So we'll start with adjuvant systemic therapy for the curative. So we're talking about curative intent, huh? So curative intent, adjuvant systemic therapy. So again, it's just been shown that, like, if you are, besides surgery and radiotherapy, if you are giving adjuvant systemic therapy, it improves the survival, and it's recommended for all patients with curable breast cancer. So like when you are doing the curative intent, and either it's used with either they are node positive, or if they are node negative, then they are high risk. So again, you need to use adjuvant therapy. And again, if they are hormone receptor positive, you again need to put them on those endocrine therapy. Similarly, you have so these numbers are showing that, like, if you put them on adjuvant systemic therapy, and depending on their stage, so either it can be chemotherapy if they are hormone receptor positive, like in any patient who has, if you, an example, for example, if you get a scenario where they are ERPR positive, or estrogen receptor positive, so you know you can put them on like these endocrine therapies, hormone therapy, which can include tamoxifen, can include aromatase inhibitors, and then some others as well, which will benefit them. Besides other systemic therapies, like if they need chemotherapy, probably yes, you put them on chemotherapy, but you can also add the hormonal therapy. If they are HER2 receptor positive, then you can put them on antibodies against the HER2 receptor. So again, presence of these receptors means like these receptors are contributing to the proliferation of the tumor. So if they are left alone, they will have a bad prognosis. Like if they have presence of HER2 receptor is a bad prognosis. But after we found the targeted therapy against HER2 receptor, then giving that therapy has made the prognosis better. So if you inhibit those receptors, then you are inhibiting the growth of the tumor. So like HER2 targeted therapy has reduces recurrence by approximately 40%. So all patients with invasive hormone receptor positive tumors should consider the use of hormone modulating therapy. Most patients with HER2 positive tumors should receive trastuzumab containing chemotherapy regimens. Trastuzumab is the drug which targets the HER2 receptors. And adjuvant systemic chemotherapy should not be given to women who have small node negative breast cancer with favorable histologic findings or tumor biomarkers. So now talking about chemotherapy. Now we're talking about adjuvant chemotherapy with curative intent. Okay. Again, chemotherapy has been shown to reduce the risk of recurrence and reduce the breast cancer specific mortality in these patients, and especially those who are below 50 years of age. You don't need to memorize the specific indications. So now which chemotherapy? Now we are talking about the curative intent adjuvant chemotherapy. So there are different chemotherapy agents which can be used. So and there are different regimens. So always they are used in combination, and there are different regimens. So like there are anthracycline and cyclophosphamide containing regimens. So as like doxorubicin, many of these drugs are well known with their brand names. So like you see the short forms where they are using the initials of their brand names. Like doxorubicin is famous with adriamycin, with the name of adriamycin. So usually you'll see A written first. So AC is adriamycin plus cyclophosphamide. Epirubicin is another anthracycline with cyclophosphamide. Then you have cyclophosphamide plus with methotrexate with 5-FU, and then you can add taxanes to it as well. So like paclitaxel or docetaxel. And then again when it says AC and then dash and P, that means it's a sequential therapy. So sometimes they give it together, like TAC is like giving together, docetaxel, adriamycin and cyclophosphamide. But sometimes like ACP means they gave adriamycin, cyclophosphamide, and then they gave not the same time, but after finishing that cycles of adriamycin, cyclophosphamide, then they gave paclitaxel. So it's a sequential therapy. Again, you don't need to memorize the combinations. At least you just know, okay, these are the drugs which can be used. So we have doxorubicin, cyclophosphamide, methotrexate, 5-FU, paclitaxel. These are the drugs, and there are some others as well, which I did not go into, like the carboplatins and all those things. So they can be used for the treatment as part of chemotherapy for breast cancer. That's what you need to remember. You don't need to memorize the specific combinations. Okay? So now let's go into specific drugs. So doxorubicin, you know already, huh? So it's an anthracycline. It was originally extracted from a bacteria. It intercalates DNA, so its mode of action is it interacts with the DNA by DNA intercalation, and also inhibits the progression of topoisomerase 2. And so it's an enzyme which relaxes the supercoils of DNA for transcription. So doxorubicin is preventing the DNA double helix from being resealed, and so it stops the replication and cellular proliferation. It also it is intercalating the DNA. It is inhibiting tropism 2. It also produces free radicals because it also does many redox reactions. So produces free radicals that also damages. It also messes with the epigenetics of those cells. It interferes with the methylation of those cells. So overall, it kills those cells, and it's a phase non-specific but most active during S phase. Adverse effects, as you told me, cardiotoxicity. Now, all anthracyclines do it, but like doxorubicin is the most commonly used and well studied, so it's mainly talked about that one. It causes dilated cardiomyopathy, and that's why you need to do a baseline echocardiogram on any patient you want to start them on anthracyclines, because you need to know the baseline function. And there's a drug dexroxazoxane, which can prevent this adverse effect if given together. But again, I will not test you on this particular drug. Okay, I will be testing you on doxorubicin and its adverse effect, but like not the drug which prevents it. But you need to know, because in future in other exams you might see this question. Another adverse effect is myelosuppression, alopecia, and typhlitis. Typhlitis is inflammation of the cecum, and it can be potentially fatal because it can lead to necrosis of the cecum, and then the sepsis, the bacteria going into the systemic circulation. So it can be fatal as well. Cyclophosphamide and also ifosfamide, similar. So these are alkylating agents. Why alkylating? Because why do you call them alkylating agents?
They're basic.
They have alkyl groups. So they put in alkyl groups in the DNA. So they have metabolite phosphoramide mustard, which is the alkylating agent. So it adds alkyl groups, and with that alkyl groups it cross links the DNA. Now these cross links can happen usually between these guanines at N7 position. So it can happen on the same strand, or it can happen across the two strands. So it can cross-link the two strands together, or it can make links between guanines on the same strand. Okay, and again there are different, like cyclophosphamide can do it, but there are some other drugs in this category which cannot do. So these are called bifunctional alkylating agents. So they can do like links on the same strand as well as cross links, and again it leads to apoptosis. It glues the two strands together, so it inhibits the replication and transcription and leads to apoptosis. And they are not cell cycle specific. Adverse effects, again bone marrow suppression, vomiting, alopecia, infertility, and then hemorrhagic cystitis. Why does that happen? Any idea? Yeah, so you have metabolite acrolein, which is toxic to bladder epithelium, and if you use adequate hydration and mesna, it can prevent this adverse effect, because the mesna detoxifies acrolein. Okay. Again, remember, when it comes to chemotherapy, hydration is very important. Like cancer treatment, chemotherapy, hydration is very, very, very important. And probably I told you in the heme block and tumor lysis syndrome lecture, most of the issues, like you do very good hydration, they are resolved. Methotrexate, again antimetabolite, as you told me, it inhibits reduction of the folic acid to tetrahydrofolate and it inhibits the enzyme dihydrofolate reductase. So like the folic acid that we have gets reduced to dihydrofolate and then tetrahydrofolate with the help of enzyme dihydrofolate reductase, and we need FH4 tetrahydrofolate for the synthesis of purine, thymidines, and methionine, which is important for cellular replication and growth and division. So this methotrexate is inhibiting the enzyme dihydrofolate reductase. Okay. So obviously it will cause myelosuppression, and they can have this neutropenia, they can have the megaloblastic anemia, and to prevent these severe adverse effects, we give them folinic acid. But again, it's not given. Now, what happens is folinic acid doesn't need reduction. It can get into the cycle and can help into the cellular processes. Normal cells are relatively quicker to respond to leucovorin compared to cancer cells. This is one advantage. Number two, you don't give it with the methotrexate. You give methotrexate and then probably after 24 to 36 hours later you give this leucovorin. So by that time we are assuming that the cancer cells will be killed or will have the toxicity of the methotrexate, and then you give it so that like your normal cell, like the bone marrow cells, are rescued from the adverse effects of methotrexate. Okay, so we call it leucovorin rescue. 5-FU, again it's a 5-fluorouracil. It's an anti-metabolite. It acts as a uracil analog. It's used in many cancers, including colorectal and breast cancer. So it inhibits the DNA synthesis by inhibition of thiamidolite synthetase. As I said, it acts as a uracil analog, and it's acting during S phase, obviously, and it incorporates itself instead of uracil. This thing gets incorporated into the RNA and DNA. Adverse effects will be mucositis, nausea, vomiting, myelosuppression, hand-foot syndrome, or palmar-plantar erythrodysesthesia, which is looks like this. It's more frequent erythema of the palms and soles in patients who are receiving chemotherapy. The last chemotherapy drug that we are going to talk about is the taxanes, paclitaxel, docetaxel, and so they are targeting tubulin like vincalculoids, but unlike vincalculoids, they are inhibiting the depolymerization of the micro. So they kind of they hyperstabilize the mitotic spindle, the microtubules, and that's why it leads to the failure of the chromosome segregation and cell division, and so it leads to the arrest of M phase, and that's why it because always there are checkpoints during the cell cycle. There are checkpoints. Check the DNA integrity, like whether, because during the cell cycle, cell needs to divide. For that, there is like growth of the cell, there is synthesis of the duplication of the DNA material. But then there are checkpoints to check whether everything is going well. Suppose during the DNA duplication, if there are any aneuploidies, if there are any more mutations in the DNA. So if there are any problems, then cell can go into either cell cycle arrest, G0 phase, or it can go into apoptosis, to make sure that those problems are not propagated into the future generation of cells. Otherwise, and if when those checkpoints fail, then the cancer develops. So that's the problem. So when you are with the chemotherapy, that's what you're doing. So here, because of this problem, now this checkpoint triggers apoptosis, and the cells go into apoptosis. So obviously those cells which are rapidly dividing will face this problem. So again you have vomiting, peripheral neuropathy, and myelosuppression. Now let's come to the targeted therapy, which is more important. So again, when you say targeted therapy, we are talking about targeting specific molecules, receptors, antigens which are present either on the tumor cells or in the microenvironment of the tumor. So you are targeting specific cells. So obviously, because when you are targeting specific cells, that means you will have better effect, like more effect, and you will have less toxicity. Your normal cells will be spared. So and that's why we are getting like more and more. So the treatment of the cancer is becoming better and better every day, and less toxic and more personalized as well. So now you need to test the tumors for the presence of those molecules, and if they are there, then you can give them those specific therapies. So here we will talk about this the cancers, breast cancer tumors which are expressing HER2, they are overexpressing the HER2. What is HER2? Yeah, so it's in a human epidermal growth factor receptor 2. So this is HER1 as well, this is HER2, so and the HER3 as well. So 20% of breast cancers they have amplification of HER2 oncogene, and it plays a role in the growth of the tumor. So usually presence of this thing, it means the tumor is more growing and it's a poor prognosis sign. But now we have targeted therapy, so that improves the prognosis. So associated with poor prognosis, but like prognosis improved with the development of HER2 targeted therapy. And the one drug, the first drug that came up was trastuzumab, commercially known as Herceptin. So again, it's used as H. It's a monoclonal antibody that binds to HER2 tyrosine kinase receptor. Now again, the thing is like, so suppose if you're blocking the tyrosine kinase activity is mainly like a downstream. It leads to the signaling pathways which have a role in the cellular proliferation. So it leads to cellular proliferation. So if you're inhibiting this receptor, so you're inhibiting the cell growth, signaling involved in the cell growth. The other thing that happens usually in some of these targeted therapies, when this antibody binds to this receptor, it kind of tags them for killing by our immune cells, like natural killer cells, macrophages, and that's what we call antibody-dependent cell-mediated cytotoxicity. So this is another mechanism of killing these cells. Besides arresting their growth, another way of killing is, which is more important, is ADCC, antibody-dependent cytotoxicity. Okay, so these are the two mechanisms that are involved here, and obviously all HER2 positive tumors should receive either trastuzumab, or we have some others as well, and it's effective in combination with chemotherapy as well. So it can be used with chemotherapy, and so trastuzumab is given with chemotherapy, but then obviously chemotherapy is given in cycles and not for a longer duration. But then you can continue with trastuzumab for a full year. And now trastuzumab is also associated with cardiomyopathy. It's not that common, but it can cause cardiomyopathy. So again, whenever you want to give trastuzumab, and if you're using chemotherapy, you want to avoid anthracyclines, because anthracyclines also cause cardiomyopathy. So you don't want to give two drugs which can cause cardiomyopathy. Is that clear? And you want to monitor the cardiomyopathy. Another drug in this class is pertuzumab, and sometimes we use both together, trastuzumab and pertuzumab, because it acts on the different region of the same receptor. So slightly different mode of action, but it's on the same receptor. So sometimes you can combine the two drugs together. Okay. So I won't go into details of this thing, but like you can neoadjuvant chemotherapy plus dual HER2 targeted therapy with trastuzumab and pertuzumab can be one option in some stages of this cancer. Okay. Another drug that can be used is neratinib. Again, you see this is not needed for your exam, but like again this is used. It's an like oral drug, and it also is a dual HER1 and HER2 tyrosine kinase inhibitor. So it acts on both of them, and it's FDA approved for extended adjuvant therapy. Like once you complete 1 year trastuzumab, then you can switch them to neratinib. Okay. Now here this is another concept. Like the reason I put it here, this is a conjugate. So it's antibody drug conjugate, like trastuzumab with M10C. Now there are many. See, when you are giving cytotoxic chemotherapy, is cytotoxic, so it's affecting our normal cells as well. Then there are certain other chemotherapy drugs which are so cytotoxic that you cannot give to a patient. It might kill the patient because of cytotoxicity. So the ones that we are giving, like they have adverse effects, but they are not killing. So those are the ones which are good. But then there are other drugs which are more cytotoxic. But now they found a way that if you tag that drug with something which will send that drug only to the tumor cells, and then probably you can use it. So because trastuzumab, it goes and attaches to the HER2 receptor, which is being overexpressed on the breast tumor cells. So if you are giving somebody trastuzumab, it will go and find the breast tumor cells and it will attach over there. Okay. Now if you tag trastuzumab with another drug, so trastuzumab will take that drug to the tumor cells, and then to get in the tumor cells and to cause cytotoxicity. So, like M10 and there are some others which are more cytotoxic, and normally they cannot be used in chemotherapy, but like with the conjugate therapy, they can be used. So they go and target the tumors. So this is we call antibody drug conjugate, ADC. So this is again another concept of drug delivery system. Now they are coming up with some other drug delivery system like the nanoparticles, and they are tagging the drugs with them, and so they are. I will not go into that, but I don't know. Did you get something on drug delivery systems in POD? Hmm? Like drug, like this thing, are like are nanoparticles. Like, how can you make a drug reach a certain target in the body rather than goes to the whole body? So there are drug delivery systems, and then they are being developed. I don't know, like, did they talk about this also? The pharmaceuticals, like where you have different pharmaceutical preparations? Somebody came from outside.
How to make the drug work specifically?
Yeah, how can you deliver a drug to a specific, like this one? Like, so here we're making the one cytotoxic therapy reach only the tumor cells by conjugating it with an antibody. And that antibody has receptors only in tumor cells. So this was an important concept. Otherwise, I won't test you on this thing in exam, but like you should know this concept. Okay. Now let's talk about endocrine therapy or hormonal therapy. So again, adjuvant hormone modulation therapy is highly effective in decreasing the relative risk of recurrence by 40 to 50% and mortality by 25% in women with hormone receptor positive, ERPR positive tumors. I hope by now you know this ERPR positivity, HER2 positive. You have done in pathology, so you have an idea. Huh? So we have like breast cancer tumors which can be hormone receptor positive, which are we talking about estrogen receptors and progesterone receptors, ERPR. The therapy that we are giving is targeting the estrogen receptor. So what we are, as a pharmacologist, I am concerned more with the estrogen receptor. So usually they have both. Sometimes they might have only one group, like the estrogen receptors. So if they are hormone receptor positive or hormone receptor responsive or ERPR positive, is the same thing. Huh? So as long as they have estrogen receptors, so we can give drugs which that means they are being, those receptors are being activated with the endogenous estrogen. Sometimes those receptors may be like auto-activated, and then they are contributing to the growth of the tumor cells. So you want to inhibit the stimulation of those receptors. Either you can give something which can reduce the endogenous estrogens, or you can give a drug which can go and bind that receptor, or you can give a drug which can down-regulate that receptor. Because you just want to inhibit the stimulation of those tumor cells by these hormone receptors. That's the purpose. Okay. And whether they are like premenopausal, postmenopausal, they benefit from it, and this benefit is independent of their age. So we have selective estrogen receptor modulator, tamoxifen, and then we have aromatase inhibitors like anastrozole. We have others as well, but like for your exam only one drug. But probably you might have done others in some other lectures, like letrozole or exemestane. So let's talk about tamoxifen, which you have done in POD. Huh? So estrogen receptor antagonist or agonist. So it's mixed. It is agonist on certain tissues, antagonist on other tissues. Okay. So it's antagonist on the breast tissue and agonist on the bone and endometrium. This is important. So it's indicated in estrogen receptor positive breast cancers, and it's a competitive antagonist on the estrogen receptors of the breast to prevent the receptor activation by endogenous estrogens, so it decreases the breast cancer cell growth. That's the mode of action. Okay, and typically it's given as a 5-year regimen, but like sometimes it can be given for 10 years as well. So different uses. It's used in early stage estrogen receptor positive breast cancers as an adjuvant therapy. It's also used in the metastatic breast cancer, estrogen receptor positive metastatic breast cancer, also in DCIS, LCIS, and also one off-label use is ovulation induction. Adverse effects, any idea? Endometrial hyperplasia. So main adverse effects are like nausea, like the common ones are skin rash, hot flushes. Hot flushes because of antagonistic. So some are because of antagonistic effect, others are because of agonistic effect. And one important one is which can limit the use of these drugs is the endometrial hyperplasia and endometrial risk, increased risk of endometrial cancer. It's an agonist effect. On endometrium, it's an agonist effect. It can also increase the venous thromboembolic events, and sometimes it can also induce hypercalcemia in these patients. And there we have some other effects as well. Aromatase inhibitors like anastrozole, it reduces the estrogen because aromatase inhibitors reduces the estrogen production. Okay, and obviously you want to use it in the postmenopausal women. If they are functioning ovaries will produce estrogen. So no use of inhibiting the aromatase. Okay. So, okay. I'll just try to move on. So postmenopausal women with hormone receptor positive breast cancer may be offered aromatase inhibitor initially or after tamoxifen therapy. And again, HER2 status should not affect your decision to give hormone therapy. That's dependent on the presence of hormone receptors. Bisphosphonates, again, the role of bisphosphonates is typically, obviously, you want to give because they have bony mets, so they have bony pain, so it helps with the bony pain. It also helps with the strength, the bone strength. Also, it reduces the hypercalcemia in these patients. But another effect that I came across and I was surprised is it reduces the risk of cancer recurrence, especially in bone, and improve breast cancer specific survival, primarily in postmenopausal women, which was surprising for me. How, I don't know. And you know the adverse effects like esophagitis and all those things. This was adjuvant systemic therapy for curative. Now this neoadjuvant therapy, again you can. Why you want to neoadjuvant? Because you want to reduce the tumor size, so you can do a breast conservative surgery as well. And then, if they are stage 4, then probably if they are metastatic disease, then you will go with palliative therapy, which can again include radiotherapy, bisphosphonates, targeted therapy can be used in a patient who are stage 4 and you want to give palliative therapy. So now we are talking about the metastatic disease, palliative therapy. Again, there is a role of hormones. Now it's the same hormones, but like one additional thing is coming up is fulvestrant. Fulvestrant is estrogen receptor degrader downregulator. So it accelerates the degradation of the estrogen receptor. And it is used in advanced breast cancer who are ER positive. Another drug, as I said, like in the cell cycle, there is a role of cyclin dependent kinases. So if you inhibit cyclin dependent kinases, they again they divert the cells towards the apoptosis. So one such drug is ribociclib, which is a CDK4/6 inhibitor. So CDK4/6 inhibitor plus aromatase inhibitor is a gold standard therapy, and the first line setting we are talking about the metastatic disease, palliative therapy. Okay. This again you can ignore now. Probably I'll make more lines in grey, so I'll remove some more content as well. There's another drug, again we don't have time to go into this one. Then again, see, as we are discovering more and more signaling pathways being involved in the tumor cell growth, we are coming up with newer drugs as well. So there's also a role of PI3K, AKT, mTOR pathway in these tumor cells. So there is a drug which inhibits the a product of a gene like this. It's called like PIK3CA, mutated hormone receptor, positive breast cancer. So some breast cancer tissues, they have this receptor, part of which is mutated, and that the mutation, the gene which is mutated is PIK3CA, and it is involved in the PI3K pathway. PI3K is phosphatidylinositol 3 kinase, and it stimulates the AKT stimulates the mTOR. So this Again, I won't test you on this drug analysis, but it's for you just to understand that there are more pathways involved in this growth of these tumor cells, and then we have more and more drugs coming up targeting these signaling pathways. Okay. So you can use also a combination of pertuzumab, trastuzumab, and docetaxel as a first line for HER2 positive metastatic breast cancer. Now, another issue comes up, tumors which are triple negative, like those which are hormone receptor negative as well as HER2 negative. Now you don't have these targeted therapies for them, so they have poor prognosis. So what to do? So there is some role of immune modulation, and the drug which is currently widely used as an immunomodulator in these patients is pembrolizumab, which is an anti-PD-1 antibody. It's an immune checkpoint inhibitor. We did these immune checkpoint inhibitors in POD. Good. And also I did these things with you in lung cancer, CVP. Yeah? So it's an FDA approved and it's used in combination with chemotherapy for metastatic triple negative breast cancers. Okay, so that's the only thing on the slide. Those patients who have BRCA1 or BRCA2 mutation, you can use another drug which targets the PARP and at kind of, so there's one insult already, BRCA1 mutation, then you are synthetically inducing another mutation. So you have problem with the repair of the double DNA breaks, like double strand breaks, and now the other drug that you're using is impairing the repair of single strand breaks. So this is called synthetic lethality. So with this drug, this is what you're doing. So we have this olaparib, which inhibits the PARP. But again, you don't need to worry about this drug for the exam. Okay? I think that's it. Any questions? Now you can wake up. Huh? So again, this is the final list that you need to know of drugs. The remaining drugs you don't need to worry about.